Thank you, Dr. Glebe. Good morning, everyone, and I'm glad you all found our new location for rounds. And really, in the next 30 minutes, I'd like to go over indications for repair of varicoceles in the adolescent and in adults. And what initially pointed me towards this topic was some work with Dr. Afshar and Jen Locke. And as I read more about the literature, what I realized was there's a lot of published data, but we actually don't really know much about varicoceles in some ways. And there's no consensus really in a lot of the indications. And as a roadmap, today or this morning, I'd like to go over briefly the etiology and pathophysiology of varicoceles, then switch gears into adult varicoceles and indications for repair. Consciously, I left out pain, and I went with fertility and low testosterone in the interest of time. And lastly, looking at varicoceles in the adolescent and the evidence supporting some of the classic indications that we know. So a varicocele is an abnormal enlargement of the pampiniform venous plexus secondary to retrograde flow of blood to the testicle. It is predominantly left-sided, and in terms of population studies, they've noticed that there's an increased prevalence in first-degree relatives of patients with varicoceles, particularly in brothers. And many theories exist as to why varicoceles occur, and they include first off, incompetent venous valves, thus allowing retrograde flow of blood. One thing that makes this theory unlikely was later on they saw that there were males without varicoceles who have incompetent valves, and conversely there were males with varicoceles who had competent valves themselves. The next is a difference in hydrostatic pressure between the left and right testicular vein, as the left testicular vein is much longer going into the renal vein rather than the right, which goes into the cava. Logic would dictate, however, that if this was truly the case, that at least most males, if not all, should be affected. So the last two really have been, this is what we think is happening. One is being related to the testicular vein being pinched off by the SMA and aorta, known as the nutcracker effect. And this then leads into an increase in hydrostatic pressure by the compression of the vein. And finally, one of the more recent ones has been that there's an increased arterial blood flow to the testes that occurs during puberty. And this exceeds the venous capacity, resulting in venous dilation and varicocele formation. These were based on animal models, and they think this translates into humans, but I don't think there's any studies yet that really showed that.
Why the left-sided arterial?
Truly, I think what it sounded like was that it was more of this is what they observed rather than providing a true etiology from what I gathered. So given its intimate location and relationship to the testes, varicoceles can have profound effects on the organ itself and its function. Historically, the main concern had been its effects on spermatogenesis, and these are postulated to occur through several mechanisms. One is that the pampiniform plexus itself surrounding the testicular artery is thought to allow for heat exchange. And combine that with scrotal positioning, together they regulate optimal temperature for spermatogenesis. Stasis of blood in the varicocele itself, with resultant temperature increase, is then believed and shown to have negative effects on spermatogenesis. Another thing is hypoxia resulting from the stasis of blood. This then affects partial oxygen pressure and metabolism in the testes. Another postulated mechanism is something called adrenal reflux, where a phenomenon where reflux of blood down the testicular vein has been demonstrated in some patients with varicocele. This is then thought to lead to exposure of the testes to adrenal and renal metabolites and contribute to testicular damage. Last but not least is the formation of free radicals resulting from the above conditions of hyperthermia and hypoxia. This then leads to germ cell harm and testicular function impairment. So these were some of the pathophysiology when I looked at a lot of the reviews, recent and prior. So the clinical grading system proposed by Dubin is commonly used, and this is purely based on physical examination. This is with a patient in standing position, and grade 1 being only palpable on Valsalva maneuver, grade 2 being palpable with no Valsalva maneuver, and lastly grade 3 visible with no need for palpation. And, the image on the right shows a grade 3 Dubin classification. And recently they also include grade 0, which is a subclinical varicocele, or what is considered varicocele diagnosed by ultrasound imaging alone. Next, I'd like to talk about indications now for repair of varicoceles in the adult. To put things in context, 15% of men in the general population have a varicocele. And when you look at men with primary infertility, 40 of those have a varicocele. And when you we look at men with secondary infertility, they've had kids before and now we're trying again and can't, 81% have a varicocele. And whether it's due to a change in societal trends with couples delaying pregnancy and childbirth, or an appreciation and awareness of male factor infertility, varicoceles are something that most urologists already encounter, and for us residents, something that we will for sure see in clinical practice. So for me, despite one of the varicoceles being one of the most common identifiable causes of male infertility, 80% of men with varicoceles are fertile. So it's a bit tough, because this really creates a dilemma for us as to see which are the patients that we need to pick out as those that need intervention. Another issue is that most studies use semen parameters as endpoint, and these are supposed to be as a surrogate outcome for fertility. Ideally, what we would want are pregnancy rates, or better yet, live births. And most studies that's available out there already show that the presence of a varicocele causes abnormalities in semen parameters, and repairing them improves them. But again, we don't know if this translates to what the endpoint that all our patients want, and that's why they come to you anyways. So when looking at the evidence, I figured I'd start with, how does varicocele repair affect semen parameters? And I took this meta-analysis, and this is one of a number, that looked at effect of varicocele repair on sperm parameters. 22 studies looked at effect of varicocele repair on sperm concentration, 17 on motility, and 5 on progressive motility before and after varicocelectomy, and all were prospective trials. To recap, in this forest plot, right of 0 favors treatment, or treatment shows benefit, and left means control. And looking at sperm concentration alone, again, these were 22 studies, varicocele repair improved sperm concentration after, or there's a trend towards improvement or benefit. When you look at progressive sperm motility, which is the sperm's ability to swim in a straight line and not just wagging its tails, both progressive sperm motility and overall motility is also improved with varicocele repair. And again, big question, are people getting pregnant with repairs if they're coming in for infertility to begin with? And there's really a lack of published literature on that, and Dr. McCann and I were actually chatting, and he had one paper that was from Iran that he shared to me about pregnancy as an endpoint, and I chose this one because something else actually does exist, but again, you'll see some holes in the study. So for this paper, they wanted to determine whether varicocele treatment is superior or inferior to no treatment in male infertility from an evidence-based perspective. And when I looked at what type of study is this, I took this as a direct quote from the paper, and I actually have no clue what prospective, one-to-one concealed to randomization controlled, parallel group, non-blinded, open-label fashion means. So I went into what they actually did. So primary outcome was determining spontaneous pregnancy rate during a 12-month period after receiving the allocated intervention. And this case was a subinguinal varicocelectomy. Inclusion criteria was you had to be married, overall healthy, 20 to 39 years of age, infertility for with greater than 1 year of regular unprotected intercourse, a clinically palpable varicocele, and at least one impaired semen parameter. Didn't matter what it was. Exclusion criteria, there's a number of them, and it looks like they try to control for some of the other environmental or extraneous factors that may contribute to infertility, like significant medical disease, smoking, occupational heat exposure. That's what they're thinking of. associated female factor infertility, or an unstable marriage. That was the other one that stood out.
Do you have criteria for that?
I actually was looking what that meant, but you also had to be married, and I don't know, to be included in this study. So patients had to willingly accept either immediate varicocelectomy, and that was the treatment arm, or observation for 1 year, and you can reevaluate the management plan, and that was the control arm. And there's computer-generated random allocation as to which arm the patient went to, but obviously once they were randomized, the investigators and the patient would know where they fell because you either got a surgery or you didn't. And as mentioned, it was through a subinguinal microsurgical varicocelectomy, and they did semen analysis at 3 months, 6 months, 9 months, and 12 months, and any pregnancy noted during that time was also recorded. So this is how the result, like how it all played out. So 75 patients each initially to treatment arm and control arm. A couple were lost, or a few were lost to follow up. So in the end, 72 patients were in the control arm and 73 in the treatment arm. And in terms of their data, the first one was all 3 sperm parameters that they looked at improved after varicocelectomy. And that's not surprising. Most of the data already showed that from previous studies. And this is when you look at those in the treatment arm and when you compare the treatment arm to the control arm. The other thing that they looked at was, of course, the pregnancy rate. That was their primary outcome. And they saw that spontaneous pregnancy was achieved in 14% in those in the controlled arm versus 33% in the treatment arm. But as you can see, the numbers overall are quite low, 10 of 72 versus 24 of 73. I think this is a good start, but hopefully this is with this plus the paper from Iran that Dr. McCann showed me that more of this will hopefully be down the pipeline, that they actually look at pregnancy and fertility, because as you can see, it's not really yeah.
What were the pregnancy rates in the 2 arms?
In 10 of 72 or 14% in the control arm, 24 of 73 or 3% in the treatment arm.
That's odds ratio of 3. It's
Yeah. Oh, I think it's statistically significant for sure. And there's so few that I'd like to think that varicocelectomy helps, and the mechanism makes sense in a way, but I think I only saw 2 studies as of right now that actually looked at pregnancy rates.
What was their assumptions going into the trial design based on their sample size that they chose? Did they have main priority? Usually have main priority sample size. What's the control pregnancy rate in the established literature? Does that know?
It's a great question. I don't know this paper at all. I'm embarrassed to say, but when we did a study, we used 2 years of unprotected intercourse.
Mm-hmm.
In our study, 6% of patients with 2 years of unprotected intercourse and varicocele had abnormal semen analysis at pregnancies.
So pretty close. Is it 10? You said 10%? 14.
So
This is a younger population than we see. Our infertility patients tend to be in their late 30s.
and this one was like very selective. I don't know how they did it, but they were able to really screen for the patients going in.
So they ensure that female factor for infertility was controlled.
They said they did, but they didn't show in terms of was that either through testing or questionnaire, or like have you gone to see a gynecologist or something. I didn't know what the screening tool was actually. Other notable findings is that improvement in semen parameters are also found in patients with varicocele repair due to other factors like testicular pain, discomfort, or cosmesis as the primary indication. The degree of sperm impairment was associated with varicocele grades in a lot of the studies. Most significant improvement in semen parameters occur at 3 months post-repair, either surgically or embolization. And again, the theme of this was uncertain if this translates to the main goal. Now, in the, 7-8 years, there's additional tests now that have been developed to look at the different aspects of sperm function in the presence of a varicocele that maybe cannot be identified by conventional analysis. And these include sperm DNA fragmentation tests and testing for reactive oxygen species. And I'll show which particular compounds it is. And this review that I saw, a group from Cleveland, was actually a fantastic review on what was the past, which was the semen analysis, what is the present, this, and what they think is happening in the future. So the premise behind sperm DNA fragmentation tests is that reactive oxygen species, as a result of oxidative stress, can inflict damage to mitochondrial and nuclear DNA. And this results in base modification, strand breaks, and chromatin crosslinks. This may also trigger an apoptosis-like process affecting maturation. And what they've already found was that there's increased levels of sperm DNA fragmentation associated with infertility, poor assisted reproductive technology outcomes, and miscarriage. Tests evaluate really single or double strand breaks occurring in the DNA. And this is just a table of the assays that's available. Although, to be honest, I'm not sure what we have here or what is done here, unfortunately, or in the cost, which...
That's just an end marker of apoptosis, right? It isn't a marker of single strand, double strand break. The apoptosis leads to DNA fragmentation and DNA laddering, so to speak. So this is just a marker of sperm death.
Yeah, and exactly. And the other thing they looked at as well was reactive oxygen species. So instead of, aside from the DNA issues, they think that increased reactive oxygen species also disrupts lipid in the sperm cell membrane, causing defects in structure and function of the sperm. And these assays either directly or indirectly measure oxidative radicals. And an indirect way, for example, looks at lipid peroxidation products, protein oxygenation products, or oxidized DNA. So these are three of the few that they look for. And direct way would be chemiluminescence. Ultimately, the question for me is, where does this all fit in? Do we order this at the same time, during, after? And the recommendation was, in this review at least, was that they use this as an adjunct to infertility workup for men with normal conventional semen analysis results. And what they champion is that abnormal test results at this point would then identify couples at higher risk of remaining childless if an expectant management is taken. I wish I knew more in terms of what we do, the availability here, but Dr. McCann did mention that we have one of the experts for these new markers that works here at Women's?
BC Women's.
BC
yeah.
Women's.
Mohammed Badawi, I don't know how many of you guys know him. He's come here from Cleveland. His name is on much of that literature. And, but he's in the recurrent pregnancy loss clinic, so that's where they're offering those tests at the present time. Most of the guys here are coming through the private infertility clinics, would be the commonest place our male infertility guys are. And they haven't kind of gotten into that. They're still using the private lab or the Genesis lab. All fertility labs.
And again, it would be interesting to know at least the cost and access to this.
Really cheap. It's a kit. It's $25 each. I was stunned. Yeah.
Oh.
Cheap it is.
That is amazing. Because usually new ones mean expensive. So really to summarize, the majority of patients with varicoceles are fertile. And what I gathered from this is if a patient comes to you already worked up for infertility, it's a bit tough they're already putting all their eggs in that basket, and varicocele repair really improves sperm parameters. The data show that, and it's unclear if this really translates to increased pregnancy rates. There's some that are finally published reports that are out there that saying it does, but in a guy who's desperate, it's a bit tough, and I can see why we would try to at least help them out by providing this intervention. These new measures of spermatic function are available and apparently very cheap, which is great. But where this best fits in the management algorithm, or which patients to give this to, do they need it or not, is this overkill, I think remains to be seen really, from big time show kind of thing. One of the other forgotten functions of the testes, in some ways, is that Leydig cells also live there, and they are responsible for testosterone production.
You only forget that in your residence.
I didn't show us. There was a slide that's why we need testosterone, and I didn't even show that because I think it'd be bad for most residents, including myself. So really, they're impaired testosterone production, and thus low serum testosterone. And when you couple that with symptoms like decreased libido, fatigue, difficulty concentrating, they term it as male clinical hypogonadism. And being biochemically hypogonadal means a serum testosterone level of less than 325 nanograms per deciliter. That was the definition they had. And there's been a lot of literature that champion, does varicocele repair improve testosterone level, and can being hypogonadal be enough of an indication to do surgery or an intervention. This was one of the larger series that's out there, a group from New York, case control study, and what they wanted to determine was whether men with varicoceles have lower serum testosterone levels to begin with, and whether repairing the varicocele helps increase that, and to what degree. So they looked at men aged 18 to 70 with clinically palpable varicoceles. All had subinguinal microsurgical varicocelectomy. And the comparison group was men presenting for vasectomy reversal. They already had kids before, and their presumption was that these guys are fertile. They've already been able to do it. Serum testosterone levels were measured pre-op, and they took it between 8 a.m. to 10:30 a.m. And serum testosterone was repeated again between 3 to 12 months post-op for those that got the repair. When just looking at baseline to begin with, 325 men with varicoceles were included in this, compared to 510 in control. Those with varicoceles had significantly lower serum testosterone levels in the comparison group. That's 416 nanograms per deciliters versus 469. This was significant. Interestingly, serum FSH and LH were within a normal range of patients with varicoceles, even though the mean testosterone level was low. And I don't know why, if this means they were truly hypogonadal, or is this within the limitations of the test in itself, was something that stood out. And when they looked at men post-varicocelectomy and looked at their testosterone levels, only 200 were included in this because 125 were lost to follow-up. Serum testosterone levels were significantly greater post-varicocele repair compared to pre-surgery levels, 358 versus 454. Dr. Cleve has, it looks like you have something to, yeah.
Sure, Larry's about to say
Yeah.
something.
Dr.
If you only have one testicle, would your serum testosterone not still be normal? The reason I mean, what's wrong with the other testicle? If these are predominantly unilateral varicocele. And same for your semen analysis. Why if you only have one testicle, would your sperm count not be normal, or within normal range?
I thought you'd be one functioning testicle is enough to.
Journal was that published it.
This one was BJU, Original Urology, I think.
One of the theories is that these patients have central defects as well. When they have varicocele, they have problems with the hypothalamus pituitary.
Yeah.
But it's something that is statistically significant isn't necessarily endocrinologically significant.
Mm-hmm.
You've got a normal serum T, don't you, there? Aren't they all?
Yeah, based on the definition, they.
I don't know if Tom's going to talk to this, but this article generated a very interesting series of editorials in the urologic literature after. I don't know if you're
Oh, I wasn't
going to
gonna.
do that. So all of these comments that you guys have made went back and forth amongst the thought leaders of urology.
And when they looked at the breakdown, really you'll see it even more is that 30% of patients actually did not have any change in serum testosterone levels when they looked at those after repair. And they also saw age, mean testicular volume, varicocele grade, had no association or did not predict in change in testosterone levels. And when you look at other papers, that it doesn't matter what modality you use. This was from an Israeli group, and they used embolization, and This had 83 patients. They measured testosterone pre and post varicocele embolization, and mean serum testosterone did increase as well, 348 versus 496 at this time.
About the validity of the control group, were they assessed before or after the vasectomy? Was there any change?
They didn't assess after for this one.
They were pre-op
They were at baseline. Was it?
prior to reversal.
They didn't find that. And really to make things, to throw another wood to the fire really would be there's also challenges with measuring testosterone as an outcome, and this is just a short table as to what the issues are with testosterone variability. There's diurnal variation, age, geography, lifestyle factors, seasonal factors, the assay itself. So already, to me anyways, there's a lot of question marks and poking holes at purely using this as an indication. And my other question for me is that, does this translate really? Do they have symptoms to begin with? I wanted to know that. Do they have symptoms to begin with? Does it actually improve? Are they validated questionnaires that they use? And my take home for this was serum testosterone measurements are prone to variation. So something to keep in mind when you're evaluating these papers. In patients with a varicocele and low serum testosterone, varicocele repair may increase serum testosterone levels, but I for one am not sure if this translates to being clinically significant, not just from a numbers point of view, but from a patient point of view. Switching gears now, because given the impact of varicoceles in adulthood, some have raised a question as to whether early repair in the adolescents can improve fertility, can decrease those effects downstream. And I'd like to look at the evidence behind some of the practices in the pediatric realm. So varicoceles are uncommon in boys under age 10, and when they reach puberty, the prevalence typically range from 10 to 15%. And since fertility testing is not typically performed in adolescents, testicular asymmetry has classically been accepted as a potential indicator for long-term subfertility, and thus an indication for repair. Testicular size can be estimated clinically with an orchidometer or via ultrasonography. And the threshold values for what they consider significant asymmetry range from 10%, left smaller than right, relatively speaking, 15%, 20%, or an absolute differential of 2 to 3 cc's. And again, there's no firm cut point of what we should use, and each institution actually uses something different. In the few studies that do have semen parameters, abnormal semen parameters have been correlated with testicular volume differentials as low as 10% and are becoming more dramatic when asymmetry is greater. The big issue with looking at asymmetry is that asymmetry can be part of the normal testicular development, as the testes enlarge at different rates even amongst patients. This notion of catch-up growth in patients with varicoceles was published by a group from Philadelphia, and they did a retrospective chart review of patients 18 or younger with a varicocele in their center from a 10-year span. 71 patients satisfied this criteria, and they excluded patients with scrotal pathology, previous inguinal surgery, or endocrinopathy that might affect size. They were interested in patients with no initial treatment and at least 3 follow-up ultrasounds 12 months apart. And of these 71 patients, we get even to less numbers now, 38 had greater than 15% asymmetry for what they use. And 27% of 38 had eventual normalization of this. And to the right, this graph shows age versus age of testes volume normalization, meaning the shaded lines represent percent of patients who normalize to less than 15% asymmetry. And this shows that the majority of the patients had normalization regardless of age at the measured difference or asymmetry. So it didn't matter if you saw it at age 12 versus age 15. What they showed us, they all catch up regardless of that. And from this, the authors recommended that at least 2 or 3 follow-up ultrasounds to measure volume is what they recommended, be 1 year apart, to be done prior to performing surgery. And interestingly, the commentary in itself already had pediatric urologists saying, I don't want to wait 3 years. I think that's too long, or even 2 years, because the asymmetry is too large, and I think we're causing harm. So,
Thomas, we just go back on, I mean, you only had one patient actually had 100% catch-up there.
Yeah.
Far right, at age 16, there's only one.
I think in terms of, well,
I don't
in
think you can say that they all catch up in growth. I think is that a fair extrapolation?
no, I don't like. I think I think catch-up growth happens, and I think this data doesn't really, it doesn't provide how to select for it, and I think this N of 1 just shows it, but again, it's so small that I wouldn't hang clinical practice on it necessarily. So the important methods to really consider are measuring volume as prone to error and still involves subjectivity. Testicular asymmetry can occur as a normal process and can enlarge at different rates. The next question is, how can we exclude the late bloomers, right? That's really what you want to pick out and reassure them and not have to stress them out and not perform unnecessary procedure. So one of the things that is emerging as a predictor is of progressive asymmetry is peak retrograde flow, and a group from New York was one of the first to really champion that. And really, it's a measurement of peak retrograde flow, venous flow in the spermatic cord via Doppler color flow imaging. The patient is performing Valsalva maneuver in the supine position as they are doing this. This was a retrospective review involving the institution's varicocele database, and their aim was to whether varicocele grade or duplex Doppler ultrasound measurement of peak retrograde flow could be used as a predictor of persistent, progressive, or new onset asymmetry. And their definition, again, just shows you the heterogeneity, is 10% or more difference in volume as asymmetry. And they divided peak retrograde flow in centimeters per second as to greater than 40, 30 to 39, 20 to 29, or less than 20. 77 patients were included, and the mean interval between two ultrasounds was 13 months. Most of the patients had clinical grade 2 or 3 varicoceles. From my take-home point from the data they presented, really, with the left column being follow-up, is that catch-up growth rates are rare in patients that have 20% asymmetry and a high peak retrograde flow. Short of that, I think it's hard to really draw conclusions. You can't really exclude patients saying, hey, you know what, your peak retrograde flow is really low, we don't need to follow you. I think it's something that you can't really take from this data, but at least you have an alarm bell, was what they argued, if these two parameters are in play. And although not typically performed, there is some data on semen analysis and varicoceles in the adolescent. And this group performed semen analysis on 57 tenor stage 5 adolescents with varicocele. They wanted to look at varicocele grade, testicular volume, differential, and semen parameters. Not surprisingly, similar to the adult literature, as percent asymmetry increased, there was decreased sperm concentration and total motile sperm count, with the adult literature not being the asymmetry part, but having a varicocele that affects semen parameters. And of course, as per the theme of the topic, it is never as straightforward as it seems, because there's been a few studies that show that that semen analysis normalized without actually you having to do anything. And this also goes back to the idea of catch-up growth, asymmetry. Is this something that we should just wait and see first? An important consideration is that sperm morphology changes throughout the different stages of puberty. So what is really normal at what age is to be determined. We don't know what normal is. They're graded against the adult standards, and range of semen analysis, what is considered normal, is already vast to begin with as well. Thus, arriving at a set point is quite difficult in terms of a point to see surgery would be needed, surgery would not be needed. So I think patients should be followed regularly with serial physical exam and assessment of testicular size as bare minimum, whether you use an ergometer or an ultrasound. I think what take home was just be consistent with it and know that there's a lot of variability. And there's still no consensus on what threshold we should use. And peak retrograde flow may be helpful in selecting these patients, but there are a lot of groups out there that don't even use it as well. And last but not least, semen analysis can be considered, maybe in those with consistently equivocal findings. With the understanding though that there are limitations to the test, and I think you really have to counsel the patients on what they mean, what you're looking for, and what this may entail. So I hope you're confused enough. I was. But in no particular order, I'd like to thank Dr. Nigro, Dr. McCann, Dr. McNeely, and Dr. Afshar for at least helping me put together the presentation. Questions?